Hello Dentospedia learners. In today's case study, we'll discuss another important high-yield topic for all dental board exams. We'll move step by step: history, findings, investigations, questions, and exam tips. Here is your clinical scenario for this case study. Refer to this information for questions 1 to 5. Sarah, a 15-year-old girl, is brought by her mother with complaints of loose front teeth and occasional gum bleeding. She is otherwise healthy, with no relevant medical history. Her father lost several teeth at a young age due to gum problems. On examination, localized gingival inflammation is seen around the permanent first molars and incisors. Minimal plaque and calculus are present, but periodontal probing shows 6 to 7 mm pockets in these areas, with grade 1 mobility of the mandibular incisors. Radiographs reveal an arc-shaped vertical bone loss affecting the first molars and incisors, while other teeth appear normal. Subgingival plaque analysis commonly identifies Aggregatibacter actinomycetemcomitans in such cases. Let's have a quick breakdown of the patient's profile: age, gender, chief complaint, and medical history. Sarah shows localized gum inflammation around molars and incisors, with minimal plaque but deep 6 to 7 mm pockets and slight mobility. Radiographs confirm arc-shaped bone loss in these teeth, and microbiology often reveals Aggregatibacter actinomycetemcomitans. Routine blood tests are normal, though neutrophil testing may be considered. Now that we've reviewed the case history, findings, and investigations, let's test ourselves with some interactive questions. I'll show you the question with 4 options, give you a few seconds to think, and then we'll reveal the correct answer with explanation. Question 1. What is the most likely diagnosis for Sarah's condition? Option A, chronic periodontitis. Option B, localized aggressive periodontitis. Option C, puberty-associated gingivitis. Option D, necrotizing ulcerative gingivitis. Take a few seconds to think. The correct answer is B, localized aggressive periodontitis. Why? Sarah is only 15 years old, yet she has severe bone loss, localized to the first molars and incisors. The radiographs show an arc-shaped vertical bone defect, there's minimal plaque compared to the amount of destruction, and she has a positive family history. These are all classic features of localized aggressive periodontitis. Now let's review the other options. Chronic periodontitis is typically seen in adults with generalized bone loss. Puberty gingivitis can cause gum bleeding but does not cause bone loss. Necrotizing ulcerative gingivitis presents with pain, necrosis, and pseudomembrane, none of which are present here. Question 2. Which virulence factor of Aggregatibacter actinomycetemcomitans plays the most critical role in Sarah's disease progression? Option A, collagenase enzyme. Option B, leukotoxin production. Option C, endotoxin release, or LPS. Option D, hyaluronidase activity. Take a moment to think. The correct answer is B, leukotoxin production. Why? In localized aggressive periodontitis, it's not just the presence of A. actinomycetemcomitans that matters. Its leukotoxin selectively destroys neutrophils and disrupts the host defense, which explains the rapid and severe bone loss in an otherwise healthy teenager. Let's review the other options. Collagenase and hyaluronidase do contribute to tissue breakdown and bacterial spread, but they are not unique or diagnostic for LAP. Endotoxin, or LPS, is produced by many gram-negative bacteria and is nonspecific. Question 3. Which systemic condition should be considered when investigating Sarah's case? Option A, diabetes mellitus. Option B, leukocyte adhesion deficiency. Option C, vitamin C deficiency. Option D, HIV infection. Pause for a few seconds and think. The correct answer is B, leukocyte adhesion deficiency. Why? Localized aggressive periodontitis in a teenager is often linked to neutrophil defects. In particular, leukocyte adhesion deficiency impairs neutrophil migration to infection sites, making the host defense weak and allowing rapid periodontal breakdown. Now let's look at the other options. Diabetes is strongly linked to chronic or generalized periodontitis, not localized aggressive forms in healthy teens. Vitamin C deficiency causes scurvy gingivitis, but not the localized bone loss we see here. HIV infection is associated with necrotizing periodontal diseases, not LAP. Question 4. What is the recommended first-line management for Sarah's condition? Option A. Gingivectomy. Option B. Extraction of affected teeth. Option C. Scaling and root planing with systemic antibiotics. Option D. Immediate flap surgery. Pause and think for a moment. The correct answer is C. Scaling and root planing with systemic antibiotics. Why? In localized aggressive periodontitis, mechanical debridement alone is often not enough. The best results come from scaling and root planing combined with systemic antibiotics, usually amoxicillin plus metronidazole, along with oral hygiene instruction. Now the other options. Gingivectomy is indicated for gingival enlargement, not for periodontal pockets of this type. Extraction is not the first step unless teeth are hopeless, which is not the case here. Immediate flap surgery may be considered later but never as initial management. Question 5. After initial non-surgical therapy, Sarah's periodontal pockets remain 6 to 7 mm deep around the first molars. Which factor will most strongly determine her long-term prognosis? Option A. The patient's age. Option B. The number of sites with residual pockets. Option C. The presence of Aggregatibacter actinomycetemcomitans. Option D. Compliance with oral hygiene and supportive periodontal therapy. Take a few seconds to decide. The correct answer is D. Compliance with oral hygiene and supportive periodontal therapy. Why? In localized aggressive periodontitis, initial treatment can reduce inflammation, but the long-term outcome depends mainly on whether the patient maintains strict oral hygiene and attends supportive periodontal care. Without compliance, relapse and progression are almost guaranteed. Now for the other options. Age explains why the disease appeared so early, but it does not decide prognosis. The number of residual deep pockets is important, but those can be stabilized if the patient is compliant. The presence of actinomycetemcomitans matters, but it can be suppressed with scaling, antibiotics and maintenance. It's not the ultimate determinant. Management for Sarah includes oral hygiene instruction, scaling and root planing, and adjunct antibiotics with amoxicillin and metronidazole. We then reevaluate after 6 to 8 weeks, and place her on supportive periodontal therapy for long-term stability. For Sarah, the prognosis is fair to good if she receives early treatment and remains compliant with maintenance. But if left untreated or follow-up is poor, the prognosis is poor, with progression to generalized aggressive periodontitis and early tooth loss. Key pearls: minimal plaque with severe bone loss in teens signals LAP. A. Actinomycetemcomitans and its leukotoxin are classic. Start with SRP plus antibiotics, and remember, long-term success depends on patient compliance. Follow us on social media. Download our app Dentospedia on Play Store and App Store.